I would first like to start with thanking you for the opportunity to present here our results on behalf of the PACER study group and my co-authors. Today, more and more people are on antiretroviral therapy. And due to the ambitious targets which are set for 2020 and also the early initiation of antiretroviral treatment, this number will only increase. Therefore, the durability of first line is very important, especially in low and middle income countries. A low availability of second line treatment is underlying this. Also, pretreatment HIV drug resistance could underlie this to reach these targets. Pretreatment HIV drug resistance is on the rise in Southern and East Africa. And due to more and more people which are on antiretroviral treatment, this also is likely to increase. We know that the impact of pretreatment drug resistance is that when you start with resistance, you have a 2 to 3 times higher risk on having viral failure of acquired drug resistance after 1 year of therapy. We wanted to know if there's also any clinical outcomes. So if you start with pretreatment drug resistance, how are you doing on the long term, and do we see any clinical effects of the pretreatment drug resistance? Therefore, our objective was to look into the association between pretreatment drug resistance and long-term clinical outcomes on first-line antiretroviral treatments. We defined the following outcomes. First, we have all-cause mortality. Second, new AIDS events. The third is the switch to second line due to presumed treatment failure. And the fourth outcome is a combined outcome of the 3 above. We wanted to look into these outcomes because they all represent poor clinical outcomes someone can get on treatments. We did this by an observational cohort study. The PACER is a very large observational cohort study consisting in 6 different countries in sub-Saharan Africa and 13 different clinics. These clinics vary. Some do have the availability of viral load testing and some don't. The enrollment of the HIV-1 infected individuals took place from 2007 until 2009. And all individuals started on an NRTI-based regimen with a dual NRTI backbone. Previous use of antiretrovirals was allowed, however not in the 30 days prior to study. We monitored these patients for 2 to 3 years along clinical care, which was often similar to the WHO guidelines. Next to the monitoring of the national guidelines, also we from the study took a study blood sample. We did this at initiation of antiretroviral treatment, and at time of switching. In this study blood sample, we determined the viral load. And in case the viral load was above 1,000 copies per milliliter, we also performed a drug resistance test. These results were determined retrospectively and were not communicated back to the sites. So a few definitions and the analysis we did. First of all, pretreatment drug resistance, PDR, was defined as a reduced susceptibility to at least one drug in the prescribed regimen. So drug-resistant mutations against drugs in the prescribed regimen. Switch was defined as a switch from first line to second line antiretroviral treatment due to presumed treatment failure into a protease inhibitor treatment. Substitutions were not considered a switch. However, if there was a substitution with a protease inhibitor, these observations were censored. We also defined unnecessary switch, which was a switch while the viral load was actually below 1,000 copies, or a switch with the viral load above 1,000 copies, however with wild-type virus, so there were no drug-resistant mutations. We performed time-to-event analysis using Kaplan-Meier and a Cox proportional hazard model, which we corrected for the fixed covariates like sex and age, and for time-varying covariates like the CD4 count over time, and the 30-day adherence by self-reported visual analog scale. I first want to show you some results of the cohort characteristics. Eventually, 2,579 individuals initiated first-line antiretroviral treatment and did have drug-resistance tests available at baseline. The median age was about 37 years, and we had slightly more females over men. Previous antiretroviral use was experienced in 4.5% of the cases, and we saw that in this time there was more pretreatment drug resistance among the group who had previous use of antiretrovirals. We've also been looking at the genotyping results at baseline, and we saw that in about 86% of the cases, it was as a wild-type virus, so no drug-resistant mutations. In almost 14% of the cases, we did find drug-resistant mutations. However, only in total, in 5.5%, there were mutations against prescribed regimen. So only the 141 individuals, so the 5.5%, were considered as having pre-treatment drug resistance. Also a note, among the almost 360 individuals who carried drug-resistant mutations, the majority was against NNRTIs. We also looked at the HIV subtype, and we saw that subtype C was most common in our study. So the first results of the time to event analysis on pre-treatment drug resistance and any poor outcome on antiretrovirals, so all-cause mortality and/or AIDS events and/or switch to second line due to presumed treatment failure. We saw that if you look at the red lines are the ones with pre-treatment drug resistance and the green one without. And you can see that there's a twofold risk on having one of these poor outcomes if you start with resistance. And we want to take a deeper look into it, what's causing this difference. So first we've been looking at all-cause mortality. And you can quite easily see that we did not find any difference between the ones who started with resistance and without. And among these mortality, 66.5% was for certain HIV related. And in the sensitivity analysis we did on only this group, we saw the similar results. You can also see that the mortality rates in the first 90 days of treatment were the highest, which has probably to do with a too late start of antiretroviral treatments and not so much with the HIV drug resistance. We've also been looking through Kaplan-Meier and the Cox model to new AIDS events, and also in this case we did not find any difference between starting or not starting with pre-treatment drug resistance. So third, we had to switch to second line due to presumed treatment failure. And you see that there's a almost fourfold increase in being switched to second line if you start with resistance. And so here's all three of them together. So in the first two, we did not find any difference PDR on all-cause mortality or AIDS events, but to switch to second line, there was quite a big difference. So we want to take a deeper look into the switching practices. So first, we have been looking at the reasons for a clinician to switch his patient from first to second line. And we saw that in almost 22% of the cases, this was based on clinical and immunological outcomes. And in about 71%, this was based on also a viral load test. We've also been looking at the viral characteristics in our study blood sample. So these were the results we had in clinics. That we saw that in the first, the red box, that about 17% was switched. However, at time of switch, the viral load was actually below 1,000 copies. We also saw that about 7% was switched to second line with a viral load above 1,000 copies. However, with wild-type virus, so without drug-resistant mutations. So actually, these almost 24% of the individuals could have been already suppressed on first-line antiretroviral treatments. So these were defined as unnecessary switches. The majority of the individuals who were switched were having a viral load above 1,000 copies and also had drug-resistant mutations against prescribed regimen. And these were seen as appropriate switches. And in the sensitivity analysis, we looked at only this group. We saw that it was more than a six-fold increase in risk on being switched. So to the conclusion implications. In our study, we saw that pre-treatment HIV drug resistance does not cause any excess mortality or AIDS events in the first 3 years of on first-line antiretroviral treatment. However, it is strongly associated with switching to second-line protease inhibitor-based regimens. So we can, from this data, we can say that pre-treatment drug resistance really drives the need for second-line antiretroviral treatment, which has major and programmatic implications in resource-limited settings. We also think that in our from our data that viral load monitoring is needed to, on one hand, avoid unnecessary switches. So these can be remained on first line antiretroviral treatment. And on the other hand, viral load monitoring can help to switch on time to a second line, so before any AIDS events or even mortality. I would like to thank all the study participants, study doctors, nurses, laboratory staff, the PACER network, the Amsterdam Institute for Global Health and Development, as well in Amsterdam as in Kampala, the Farm Access Foundation, and the Academic Medical Center in Amsterdam.